Hello, everybody. Today we're going to go over the most high-yield topics from Step 1. All of these questions are completely original. However, they do cover everything that I believe you need to know by the time you finish NBME 28. Now pop the popcorn and let's begin. For the first question, a 17-year-old boy presents to the emergency department with sudden onset severe left-sided scrotal pain that began 1 hour ago while he was at soccer practice. He denies trauma, dysuria, or urinary frequency. He vomited once from the pain. On exam, the left testicle appears swollen and elevated compared to the right. Cremasteric reflex is absent. That means it's torsion of the testes, 100%. Indeed, our answer is C. This is a surgical emergency, and the signs, the way you can tell, is sudden severe unilateral testicular pain. Absent cremasteric reflex was the giveaway, and the high riding testes. Vomiting is the autonomic response to the pain. Renal calculus would be flank pain that radiates to the groin. It's not epididymitis, and the reason why that there would be relief with elevation there. But here they said elevation worsens that pain and the cremasteric reflex is absent, not preserved. The big distinguishing factor is that cremasteric reflex for testicular torsion. Also, true story, once I was in Guatemala and I was in charge of driving home a missionary who had testicular torsion. And Guatemala notoriously has tons and tons of speed bumps. And let me tell you, while I was driving in the front, my buddy in the back with testicular torsion was not having a good time. And at the hospital, the doctor goes, "I'm sorry, guy, we're going to have to take that out." So imagine we're in Guatemala, I'm translating in Spanish, and I'm like, I got to take out the pelota, man. He took it like a champ. But if you're in Guatemala, definitely pay attention because it's thanks to the competent surgeons that he was able to be okay after that incident. But true story. Wow. Ugh, gives me shivers. Diverticulitis would be lower left quadrant pain and fever, which there is not here, so that's not the right answer. And colon neoplasm would have weight loss and anemia, but this is scrotal pain, so it's totally different. And this is a big emergency because in just 6 hours, it can cause irreversible damage. And I think it's probably helpful to distinguish this from another condition, which is ureteral calculus. Now, there you could see some sudden left flank pain, and it radiates to the groin, and it causes nausea. And the vitals would show hypertension. So you could have like a 160 over like a 110, just some high value here. And tachycardia, so you know you're at 110 per minute. So you're breathing fast, you've got hypertension, you got left flank pain and also left lower quadrant tenderness, and also mildly hypoactive bowel sounds and a negative stool, a cold blood test. And you probably have heard the word colicky to describe this pain. That's basically severe pain in the abdomen due to the gas or some sort of an intestinal obstruction. So it's that abdomen on the side pain that radiates to the groin. So the groin is the area between the abdomen and the thigh on either side of the body. And the presentation, if this were ureteral calculus, would have the colicky flank pain that radiates to the groin. We talked about that. The hematuria, which is the gross or microscopic presence of blood in the urine. And the urine analysis would show red blood cells, but no casts. There's not going to be any glomerular involvement either. And the treatment here is just going to be pain control. And if the stone is less than 5 millimeters, then it's probably just going to spontaneously pass. And it's important to know the onset of these different conditions. For instance, a colonic neoplasm would usually be insidious, not very acute. And insidious means that it proceeds in a very gradual or subtle way, but it still has some harmful, problematic effects. It's not acute, basically, is what it means in the medical context. And a colonic neoplasm would also present with weight loss, which I will write here, anemia, change in the bowel habits, but definitely not flank pain. And typically, you know, if the patient's mid to late 20s, early 20s, something like that, that's a bit too early for colonic cancer for Step 1. I mean, I just wouldn't be looking for colonic cancer in a 20-some-year-old unless there were signs, like clear signs like weight loss, anemia, and the change in the bowel, but not flank pain. Flank pain would definitely make me think of a ureteral calculus. Okay, so that's ureteral calculus, but what about diverticulitis? Well, diverticulitis usually presents with fever, diarrhea, and left lower quadrant pain. In a diverticulitis, the flank pain would be pretty unusual. You'd also expect some hyperactive bowel sounds, not hypoactive. The epididymitis, that would cause scrotal pain, so you can kind of tell the difference there from the groin pain. Also swelling and dysuria, not flank and groin. And it would not cause lower left quadrant flank tenderness. And a physical exam of the scrotum itself would be abnormal, but they didn't mention any weird findings. And so probably not going to be epididymitis. Renal infarction, that is a very rare, but I guess plausible cause of flank pain. And that typically would not radiate to the groin. What you should be looking out for in these types of questions would be thromboembolic risk factors or atrial fibrillation. And if you have somebody in their 20s, then you really shouldn't be thinking about a renal infarction unless there's a reason to suspect they have a renal infarction. You know, like thromboembolic reasons, risk factors, atrial fibrillation, something like that. Otherwise, it's much more likely that they just have a little stone. They got some deposits, much more likely. And we already talked about testicular torsion. That was what our practice question was based off of here. And the most important thing to know is that would have absent cremasteric reflex and abnormal testicular lie. So a way to really just dial this in and know that this is ureteral calculus, not something else, would be the severe flank pain, the nausea, pain that radiates to the groin, not limited to the flank or the low abdomen. So just some quick recall questions. I would ask, what kind of hematuria is seen in the ureteral stones? And to that, you would say probably macroscopic hematuria without the casts. And you might be asked, hey, what's the most common type of kidney stones in the pelvis? And lastly, just because it's so high yield, I really wanted to cover diverticulitis, and it would present with hyperactive bowel sounds. Also wanted to note that for epididymitis, that's usually going to be secondary to other STIs like chlamydia or Neisseria gonorrhea. And in older males, you could also see some E. coli problems, which lead to epididymitis. But yep, renal involvement in the infarctions would definitely be associated with some thromboembolic risk factor, which we don't see. Torsion of the testes, super painful. It's a true urologic emergency. Sudden severe unilateral scrotal pain. This guy in Guatemala, he was 20, I believe, and I did not elevate. I knew none of this. I was just driving that car, trying to navigate over the speed bumps as slowly as I possibly could, but also as quickly as I could to get to the hospital. And it was like 1 a.m. He called me. I was like, say no more. I drove 2 hours to get him. All right. In our next question, we have a 58-year-old man with a 25-year history of alcohol, presenting with difficulty walking, and he has no complaints of numbness or tingling. On examination, he is unable to maintain a straight line during tandem gait and shows wide base stance. Finger to nose testing is intact, and vibration and position sense is normal in all extremities. Damage to which of the following structures most likely underlines this patient's symptoms? All right, well, let's look at our answers and kind of dive into each one. You can see my beautiful drawing, which we'll use soon. A says the dorsal columns, and that carries fine touch, vibration, proprioception, that crosses at the spinal cord in the anterior white commissure. C, the primary motor cortex is involved in voluntary movement. The lesion there would have contralateral weakness, upper motor neuron signs if the cortex is involved. The anterior cerebellar lobe is involved in truncal coordination, particularly gait stability. And if you have a lesion there, you'll have truncal ataxia. And that is what's damaged often in alcoholics with cerebellar degeneration. So that is probably going to be our answer. And then E is standing for the VPL nucleus of the thalamus. And that would be the spinothalamics, the pain and temperature, and the dorsal columns, which is the medial and the medial lemniscus, which would be touch and proprioception. A lesion there would cause contralateral body sensory loss. That'd be the lateral, whereas the VPM would be the face sensory. So the answer is indeed D. It's the anterior lobe of the cerebellum because it's involved in unconscious proprioceptive input from the lower limbs via the spinocerebral tracts. Alcohol degenerates that region despite intact conscious sensory modalities like vibration, proprioception. They have truncal ataxia. Dorsal, we discussed this, would be vibration and also position. The spinothalamic would be associated with pain and temperature loss. VPL would have contralateral sensory loss. And the primary motor cortex would actually be associated with paresis and not ataxia with preserved strength. And it's kind of cool because the anterior cerebellum actually gives rise to your body's ability to know unconsciously where it is in space. So you close your eyes, you spin around, you're like, oh, where am I? Well, that's all thanks to your anterior cerebellum. And if that's gone, you close your eyes and you're going to stumble, you're going to fall. And that's what happens if you have anterior cerebellar damage. And so patients will try to protect themselves. They'll have like a really wide base gait so that they don't fall. But they can still kind of manage just a little bit because their conscious sensations like vibration and joint position are intact. And you have to know the tract that this flows through is the spinocerebral tract directly to the anterior cerebellum. And it bypasses the cortex. That's crazy, but it does. But you can see the anterior lobe is here, the primary fissure is here, and there's the vermis. Back here is the posterior lobe, the cerebellar vermis. Medulla oblongata right here. There are the peduncles. You can see the middle and the inferior peduncles. That's the tree of life, arbor vitae. I was actually teaching a class of 7th graders about this. There's my picture of the tree of life. Very beautiful. Looks like a seahorse, honestly. Who did it better, me or Google? So again, I'm just showing you a different perspective. This is the anterior lobe. That's the fissure. This is the posterior lobe. And here we're referring to the anterior lobe for unconscious proprioception, whereas conscious proprioception is controlled by the dorsal column medial lemniscus pathway. Again, here's another look. Anterior, posterior, cerebrum, cerebellum, pons, the pons, cephalon, that comprises the brainstem. And look at that cerebellum. Oof, the brain is so freaking cool. By the way, you guys should comment below what you believe the mechanism for free will is. Libertarian free will, not compatibilist free will. Here's the midbrain, the pons, the medulla, superior, middle, and there's the cerebellum, anterior lobe, posterior lobe, kind of looking at it from a different angle. And if you guys ever handle sheep brains, it looks identical to the human brains. You can actually see the tree of life when you cut it open. All right, so there's our last photo. I think you guys get the idea. If not from this, then at least from my beautiful drawing. And so we're going to thank our 58-year-old man here with his 25-year history of alcohol and difficulty walking. Because of that, we now know that his unconscious proprioception and wide gait is probably due to this anterior part of the cerebellum. If he had conscious proprioception problems, then it would be the dorsal column medial lemniscus pathway. But this was unconscious, and therefore it was the anterior lobe right here. So that's our answer. By the way, if he had like problems with pain sensation, then it would probably be his spinothalamic pathway. And just when you thought my drawings couldn't get any better, we have a 29-year-old tennis player presenting with weakness in turning his palms upward against resistance while keeping his elbow flexed at 90 degrees. All right, so flex your elbow at 90 degrees and then go like this. And then tell me what pops out. And I want you to do this on test day because it'll make this so much easier. I guarantee a lot of you guys would miss this question until you actually do this exercise yourself. So physical exam shows a preserved wrist flexion and extension, but limited power to resist the supination. And remember, it's like I want soup. You got to resist that supination. The reflexes are intact except for the reduced biceps reflex on the right, which the following muscle is responsible for his impaired function. The answer is actually the biceps brachii. Why? It's the main supinator of the forearm when the elbow is flexed, particularly against resistance. So you can kind of see, maybe you can see in my arm, how when I try to supinate with the elbow inflected, then you get some action from the biceps brachii. And there it is in all of its glory. Look at that, compare it to mine over here. Not mine on my body, rather this beautiful drawing I have here. The pronator does pronation, duh. Supinator is a good choice. However, this is not going to be under resistance. So it has less contribution than your biceps whenever the elbow is flexed. All right. Kind of crazy, but yeah. Flexor carpi radialis, that's the wrist flexor. That would have radial deviation. So the biceps brachii is a really powerful supinator of the forearm, especially when the elbow is flexed. And that receives the innervation from the musculocutaneous nerve. And I like to think of that because it's muscular. It's biceps brachii. It's the most powerful supinator against resistance. The brachialis is elbow flexion only. Does not supinate. That's what distinguishes the brachialis from the biceps brachii. You know how people do this and this when they're trying to show their strength? It's because you can activate those muscles differently, and you're not, by supinating or pronating, going to be activating the brachialis. The triceps are involved in elbow extension. You can see your triceps will be involved there if you extend. Does not have a role, however, in supination and pronation, and the innervation there of that extension of the triceps is the radial nerve. The flexor carpi radialis does wrist flexion. There's no action at the elbow at all, and that is actually done through the median nerve. And the pronator teres does the pronating, which is, of course, the opposite of supinating, and that's also done by the median nerve as well. To recap here, you've got your elbow flexed. Let's see this elbow word flexed at 90 degrees, and then you try to supinate it, supinator. And the nerve that innervates the biceps brachii is the musculocutaneous, which is C5 to C6. In this next question, we have a 42-year-old woman, but it could also be a man, and so the demographic I've chosen here is a man, with acute myeloid leukemia, presents with fever, dry cough, and shortness of breath. She underwent allo stem cell transplant 4 months ago. Okay, so transplant should key you into CMV, and immunosuppressive for graft versus host. That's definitely CMV. Yep, it literally tells us it's CMV. And she started on antiviral therapy that inhibits the viral DNA chain elongation after phosphorylation by viral kinases. Which of the following enzymes is the direct target? All right, so let's get down to business to defeat the Hun. What do I need to know about antivirals? Well, first of all, we should know that for CMV infections in immunocompromised patients, we're going to use something like ganciclovir. And the mechanism of action of ganciclovir is that it's a guanosine analog. And you can kind of tell because they both start with G. G, guanosine, ganciclovir. And so this guanosine analog inhibits viral DNA polymerase. Guanosine inhibits viral DNA polymerase and does that by CMV UL97 kinase, not thymidine kinase. What is thymidine kinase involved in? Because that is super crazy high yield. In fact, whenever you guys who are about to take the step 1 exam enter into the step exam and you see thymidine kinase and you know the mechanism, then thank me in the channel afterwards because this is going to be on your test. I guarantee it. It's a factoid that everybody misses. Because thymidine kinase would be for like HSV and VZV only here. Different than ganciclovir. So ganciclovir would be a DNA polymerase inhibitor for cytomegalovirus. And there's a way to remember that. It's the G and cyclovir, and also the G and guanosine look similar. So G, cyclovir, G, guanosine virus. So try to bucket them together, group them together. So our answer is DNA polymerase. It's a guanosine analog. We talked about that. It competitively inhibits the viral DNA polymerase, inhibiting DNA synthesis, particularly critical in immunocompromised patients where CMV reactivation causes tissue-invasive diseases. Integrase would be the genome integration of HIV. Reverse transcriptase would have RNA to DNA, and ganciclovir targets the DNA polymerase, not the reverse. Now, most of the time, CMV is dormant, it's silent, but you get to be immunocompromised. You have a bone marrow transplant, and now it comes back. So you give him ganciclovir, this antiviral gets phosphorylated, and then it targets and it blocks that viral DNA polymerase. It's good to know the other mechanisms like integrase, and I have a video on these, but integrase prevents the integration of the proviral DNA into host. It's like, stop that. You do not get integrated. You do not have access to this pool. I just thought back to like 12-year-old me trying to get into the pool, like a hotel. I couldn't get in because I didn't have a key card. But yeah, integrase inhibitors prevent that, the integration of the DNA into the host genome. And so activation of ganciclovir requires the phosphorylation within the infected cell. And CMV, by the way, is the human herpes virus 5, and it's opportunistic. So look out for it whenever you have a transplant. Also, ulcerative colitis, or maybe they have like HIV or AIDS, something like that. And you can transmit this a whole bunch of ways. Sexual contact, for instance, is one. Be respiratory, could be a fetus through the placenta. This could be valacyclovir, acyclovir, famiciclovir, and ganciclovir. They're all guanosine analogs. They inhibit viral DNA polymerase. Okay, the next question has to be a woman. 28-year-old woman presents with fertility. For fertility evaluation, her menstrual cycle is regular, and mid-cycle serum hormone levels show a peak estradiol concentration just before ovulation. Which of the following ovarian cell types is responsible for the conversion of androgens into estradiol? They're basically asking about aromatase, what aromatases into estradiol. And there's androstenedione, which comes from the theca interna, that gets converted into estradiol by aromatase, and the granulosa cells secrete aromatase when they're stimulated by FSH. The follicle-stimulating hormone causes the granulosa to secrete aromatase, which causes the transfer of this into this, and that's why it's elevated at her phase in the month menstruation cycle. So the theca interna cells provides these androgens that are then aromatased over to estradiol. That happens because of the granulosa cells, which are stimulated by FSH. The luteal cells, they're called luteal because they're present in the corpus luteum, and they're derived from granulosa before the ovulation follicle. And these guys will secrete progesterone. The luteal cells secrete progesterone and estrogen, but they don't actually develop until after ovulation takes place. All right, the answer is like not stromal because those are just supporting cells. And so the answer to this question is the granulosa stimulated by FSH to make the aromatase, which causes the conversion to estradiol. And it's that rise in estradiol that triggers the LH surge, and that leads to ovulation, which is that discharge of the ova from the ovary. The externa is the outer fibrous layer. The stromal is the support tissue. Corpus luteum would be the post-ovulation progesterone. It's after the estradiol peak afterwards, corpus luteum. And the theca interna would be androgen synthesis. It's crazy because the estrogen levels actually go up 200-fold during the menstrual cycle. And it all starts with the granulosa because of the FSH, because of that aromatase, which converts the androgen into estradiol. Next is question 6. We've updated our demographic. Now, this is an autosomal recessive condition, and so we're just going to say it's a 10-year-old boy or a girl. They're evaluated for progressive irritability, poor coordination, and a new rash after playing in the sun. Mother notes that they have several episodes of watery diarrhea, eating poorly, loss of appetite, red scaly rash on the back of the hands and neck, and mild unsteady gait. Labs show decreased tryptophan levels and neutral aminoaciduria. Which of the following vitamins is deficient? All right, so a photosensitive rash and neutral aminoaciduria. It's probably Hartnup disease. And that is a pretty rare genetic condition that prevents the body from absorbing certain amino acids. This especially occurs in the small intestine and the kidneys. And this is autosomal recessive, and it does occur in childhood. That's why we had the young girl, the young boy. And you get these light-sensitive skin rashes. And also you can have some problems like an unsteady gait, maybe speech difficulties and emotional instability, and then they're usually a little shorter. So for treatment, you have a high-protein diet, niacinamide supplements, and sun protection to manage the symptoms and the severity of the attack. So we mentioned this is some sort of a deficiency, but what is exactly that deficiency? Well, the answer is niacin, but I want to explain the reason why. Now, niacin, you should know it also by the name vitamin B3. This is actually used to make NAD+, which is nicotinamide, adenine dinucleotide, and NADP+. Those guys are superessential coenzymes in redox reactions. So you may have seen these guys. They're pretty popular in glycolysis, the TCA cycle, the electron transport chain, all that good stuff. And now, how exactly is niacin made? And like, what is niacin all about? Well, your body can make niacin from this thing called tryptophan. Tryptophan. I always say like tryptophan because that helps me remember what it looks like. But tryptophan is an essential amino acid, and it requires vitamin B2, which, for those of you in the back, is riboflavin. And it also requires B6, for those of you in the front, pyridoxine, as cofactors. I don't know why I said front and back. I'm just being a silly goose. And so what happens if you are niacin deficient is that you get pellagra. And you guys might have remembered the terrible Ds, right? Dermatitis, diarrhea, dementia. DDD, dermatitis, diarrhea, dementia. That's like one of those memorization things. But dermatitis would be the skin rash, especially on the neck and the arms. The diarrhea obviously would have GI, mucosal atrophy, and dementia would have CNS symptoms, the irritability, memory loss, and hallucinations, things like that. You might have been told there's a fourth D, and what is that fourth D? It is indeed death. So it can be fatal. And so why, you might be asking, does niacin deficiency cause a problem here? Like what actually is going on? Well, no niacin means that we don't have our awesome little buddies, NAD plus and NADP plus, which as if you've taken biochem, you know those guys are pretty important. And so you'll have tissues that have some high energy needs. Can you think of some tissues that have high energy needs? I don't know. How about the skin? How about the gut? How about the brain? Wow, look at that. DDD, dermatitis for the skin, diarrhea for the gut, and then for the brain, it's dementia and death, because other organs also need it as well. So niacin is required to make NAD+, and that is a key coenzyme in metabolism. And metabolism, by the way, is the process that occurs in order to maintain life. It's how you change your food into energy. That's why you can die if you don't have niacin. But why is it not these other guys? Pyridoxine would have different associations: seizures, glossitis, irritability. The dermatitis is really the giveaway, the photosensitive rash, and amino aciduria. Riboflavin would present with corneal vascularization and no diarrhea and sun-induced rash. It's really that rash that gives it away. Ascorbic acid, bleeding gums, corkscrew hair, scurvy, vitamin C. And cobalamin, macrocytic anemia. B12 deficiency causes spinal cord demyelination, not amino aciduria, and photosensitivity, so cobalamin. Be macrocytic and paresthesias. And paresthesias is the pins and needles sensation in your peripherals. And oftentimes what happens with these kids is that they get some sort of a rash and then they're like, oh my gosh, you got a rash, time to get that checked out. It's Hartnup disease. You have the genetic defect because the transportation of a neutral amino acid like tryptophan is damaged. And you need that for vitamin B3. And if you don't have vitamin B3, you're going to die and your gut's going to hate you. All right, here we have a 74-year-old man, and I've gone ahead and made him a pretty young looking dude administering this shot menacingly. He's got a prosthetic mitral valve presented with fever, malaise, and a new murmur. Blood shows it's enterococcus. In fact, the infectious disease team recommends a combination of antibiotics for synergistic bacterial killing. That's what this person is doing. That's what you're going to be doing in a hospital system soon. And one of the chosen targets is, they didn't have to tell you this. That was nice of them. 30S ribosomal subunit causing misreading of the mRNA, which antibiotic is most likely being used in combination to enhance the penetration efficacy of this drug. The answer is carbapenems. Because these guys, carbapenems, they weaken the bacterial wall and they block peptidoglycan cross-linking. This allows aminoglycosides to just come on in. But first you have to destroy that peptidoglycan cross-linking. And so you do that with the carbapenems and penicillins. Cephalosporins are less effective against enterococcus. Macrolides are 50S inhibitors, different mechanism. Fluoroquinolones target the DNA gyrase. No synergy there. Glycopeptides block the synthesis. So the core concept here is the synergistic killing of bacteria through penicillins. Because we got to break down that wall, kill the bacteria more effectively. And aminoglycosides will then enter more easily if you give them with a penicillin. Carbapenem, they bind the 30S ribosome and it blocks the protein synthesis by causing mRNA misreading. That's the mechanism. And so bacteria, they're weakened and they can't make proteins. And so essentially they're just little dead bugs. And so we have to use this before Enterococcus, Listeria, and Streptococcus species. And sometimes they're paired as like ampicillin and gentamicin is a classic combo. Are you amped up because he's a gentle guy? Well, the ampicillin helps you break in and then the gentle guy sneaks in and does his thing. It's also used in endocarditis and neonatal sepsis. So it's a big farm question, but macrolides is 50S and the penicillins. All right, the next question, we have a 9-year-old boy brought to the clinic for evaluation of behavioral concerns. His teacher reports increased difficulty with concentration, repetitive hand flapping, and social withdrawal. His parents mention that his uncle on his mother's side has similar history, and he has an elongated, narrow face, large protruding ears, and large testes for his age. Okay, that should tell us. Okay, and then they even gave us CGG. They did not have to do that. That was super nice. They're just being so nice today. Which of the following best describes? The answer is genetic silencing due to repeat expansion. And we know this as Fragile X. GG stands for giant gonad. It's a repeat expansion disorder. I made videos on this before. The gene that's affected here is FMR1 in the trinucleotide repeat, CGG. It's X-linked dominant and is actually associated with autism spectrum disorder as well. All right, in our next question, we have a 68-year-old man, could also be a female, hence this photo, demographic of photo, presents the dermatologist for evaluation of a pigmented lesion on the left temple that has gradually expanded. History of extensive sun exposure. Examination shows a 2-centimeter asymmetric flat macule with irregular borders. Biopsy shows nests of single atypical melanocytes confined to the basal layer. No dermal invasion. This is often seen in elderly patients with chronic sun exposure. Grows slowly, but it carries malignant potential. Dysplastic nevus would have irregular borders, possibly, but it'd be in younger patients and not basal layer atypia. Superficial spreading would be faster growing than this. Actinic keratosis would be a precursor to squamous, not melanocytic. Mosaic would be the stuck-on waxy appearance. In our next question, a researcher is evaluating the occurrence of new cases of type 1 diabetes in children under the age of 10 across pediatric practices. Which of the following best measures this data? All right, so really the only hard ones on this question are the incidence and the prevalence. And here what we're looking for is the keyword is new cases in a defined period of time. New cases is the incidence, whereas the prevalence is the total burden at one time, not the new cases. Okay, so here's our little kiddo wanting to do his little test for diabetes. If he is found in that year, you're tracking the new cases, it'll be added to the prevalence. But kids who did not already have the disease are included there. All right, everybody, if you found this helpful, then please consider liking and subscribing. Please let me know how I can improve these videos. I plan on doing 190 more. We'll see you guys in the next one.